I'm Sydney, and I'm excited to present our work on moving towards predicting muscle injury during vaginal delivery. My collaborators and I thank CMU for hosting this forum and you for your time and attention. 3 million vaginal deliveries occur in US hospitals every year, and this is a hugely mechanical event, particularly for the levator ani muscles, shown in this image. When they're not stretching during vaginal delivery, they actually sit contracted in the base of the pelvis to support the bladder, vagina and uterus, and rectum. They relax to allow for voiding and also to regulate intra-abdominal pressure. However, when they're damaged, this can result in pelvic floor dysfunction. Over 300,000 surgeries are performed each year for urinary incontinence, fecal incontinence, and pelvic organ prolapse. In total, 1 in 3 US women have some form of pelvic floor dysfunction, and what connects all of this is vaginal delivery, which is the largest risk factor beyond age in developing dysfunction. However, unknown injury mechanics prevent personalized and early intervention, leading to a wait-and-see paradigm. Recent work has quantified the variation of the complex muscular pelvic floor, seen here, and parts of the bony pelvis, seen here. Normal variations in anatomy, as well as remodeling during and after pregnancy, have been shown to greatly affect the shape of these structures. And this information now allows us to ask, what morphology is connected to complicated labor? And more broadly, how does morphology inform injury mechanics? To begin to answer this, we recruited 50 nulliparous, meaning never given birth before, individuals who underwent MRI in the 2nd or 3rd trimester of pregnancy. We defined complicated labor for this group as C-section due to arrest of descent or vacuum delivery, mostly because this indicates trouble navigating the birth canal. This happened in 17 of our cohort. To orient you to the anatomy, this icon of the pelvis is as if you are facing someone, but this image comes from the coronal plane, where these bones here are the base of the pelvis and these are the femurs. Similarly, this is the front of the pelvis, but this image is in the mid-sagittal plane, so as if you were turned and cut in half. Further, the bladder and urethra are outlined in red, the vagina in orange, rectum in yellow, and this is the uterus. We measured the levator hiatus, which originates at the tip of the pubic bone and extends to the back of the rectum, as well as the hiatal area, which is the area excluding the muscles that hugs the pelvic organs. We measured the anterior and posterior transverse widths, as previous work showed that this is sufficient to describe this complex shape. Lastly, we measured the curvature of the sacrum, coccyx, and sacrum and coccyx together, as well as the angle at which they meet in green. No significant differences were found between our complication and no complications group regarding maternal BMI, neonate birth weight, and head circumference. However, we did find that those with complicated labor had a narrower anterior transverse width. And we didn't find significant differences in the bony pelvis, which is surprising considering the degree of remodeling that the coccyx experiences and its importance as a muscular attachment site. We wanted to look not only at the absolute width, but the ratio of the anterior to posterior width, as this starts to give us a hint at hiatus shape. And indeed, we found that those who experienced a complication had more of a U-shaped levator hiatus, where the anterior and posterior are similar, as compared to those who had a V shape and did not experience a complication. And past work has also shown that this U shape is overrepresented in those currently experiencing pelvic floor dysfunction. So preliminarily, it looks like the anterior compartment is going to be important and the overall shape of the levator hiatus. We hypothesize that this directs the stretch of the levator ani, but future work will focus on developing finite element simulations of this stretch during delivery using the geometry and outcomes from this cohort for initial validation. We'll then move to identifying personalized targets for counseling and regenerative therapies. If you work in the area of simulations, personalized medicine, or especially regenerative medicine, I'd love to hear what you think of this work and the possibility in collaborating. Email is the best way to reach me, and thank you to the Biomechanics and Regenerative Medicine program and to you for letting me into your computer.